I want to talk to you today about a small capsule that an extraordinary number of people over 70 take every single morning, often for years, frequently for decades, and very often without anyone ever having reviewed whether it's still needed. Omeprazole, or lansoprazole, pantoprazole, esomeprazole, rabeprazole, the family known as proton pump inhibitors, or PPIs. They are among the most prescribed medications in the world, and for good reason, because they are genuinely excellent at what they do. They heal ulcers, they control serious reflux, they protect stomachs from damage caused by other medications. And for some people, they are unquestionably necessary and beneficial. And at the same time, they are probably the single most over-continued medication in modern practice. Studies looking at long-term users repeatedly find that a substantial proportion of people taking them have no current clear indication, meaning the original reason has passed or was never firmly established, and the prescription has simply rolled forward year after year on repeat. So today I want to give you the balanced picture, what these tablets do, when they're genuinely important, what long-term use may cost you, and most usefully, the exact question to ask and the correct way to come off them if you and your doctor decide to, because stopping badly is why so many people conclude they can't. So today I'll explain how these tablets actually work, the conditions where they're clearly justified, the concerns about long-term use stated honestly rather than alarmingly, the nutrient deficiencies that genuinely matter after 70, the interaction that could affect your heart medication, the rebound problem that traps people into taking them forever, the right way to stop, and the warning symptoms that mean you need investigation rather than a stronger tablet. Let me begin with the mechanism. Let me explain what these tablets do because it's rather remarkable. The lining of your stomach contains cells with tiny molecular pumps called proton pumps that push acid into your stomach, and this is deliberate and useful. Stomach acid kills swallowed bacteria, activates the enzymes that begin protein digestion, and helps you absorb several nutrients. Proton pump inhibitors work by irreversibly disabling those pumps, and they are extremely effective, reducing acid production dramatically, far more so than the older antacids or the H2 blockers like famotidine. And two practical points follow from the mechanism. First, they are not fast-acting. They don't neutralize acid that's already there. They stop new acid being made, so they take a day or two to reach full effect and are not the right choice for immediate relief of heartburn, which is what antacids are for. Second, and this is the tip most people are never given, they work best when taken on an empty stomach, roughly 30 to 60 minutes before your first meal of the day, because the pumps are most active when stimulated by food, and the drug needs to be in your bloodstream at that moment. An enormous number of people take theirs with breakfast or at bedtime and get considerably less benefit than they could, so if you've been told your tablet isn't working well, check when you're taking it first. So these disable the stomach's acid pumps, they take a day or two to work, and they should be taken half an hour to an hour before breakfast. Now, when are they genuinely justified? Let me be clear about when these medications are clearly appropriate, because I don't want anyone stopping something they genuinely need. They are justified, often long-term, for a healed stomach or duodenal ulcer, particularly if you've had a bleeding ulcer, for Barrett's esophagus, a change in the lining of the food pipe caused by long-term reflux, for severe biopsy-proven inflammation of the food pipe, for a rare condition called Zollinger-Ellison syndrome, and very importantly for this audience, as gastroprotection, meaning stomach protection, for people who must take medications that damage the stomach lining, particularly regular anti-inflammatory painkillers, and for certain people on aspirin or anticoagulants who have additional risk factors for bleeding. That last group matters a great deal because, as I've said in other videos, the combination of aspirin or blood thinners with anti-inflammatory painkillers is one of the classic routes to a serious gut bleed, and a PPI substantially reduces that risk. They are also entirely appropriate short-term for a course of a few weeks to a couple of months for uncomplicated reflux, for treating an ulcer, or as part of the antibiotic combination used to eradicate Helicobacter pylori, the stomach bacterium that causes many ulcers. Where the question arises is the very large middle group, people who started 1 year ago for indigestion or reflux that has long since settled, or who were given one during a hospital stay and never had it stopped, and who are still taking it now with no current clear reason. That is the group this video is really for. so they're clearly justified for ulcers, Barrett's, severe inflammation, and stomach protection alongside risky medications, and the question mark hangs over long-term use for symptoms that resolved years ago. Now, the concerns, honestly. Let me go through the long-term concerns, and I want to do this carefully because this topic attracts a great deal of exaggeration in both directions. The honest summary is this: most of the concerns come from observational studies, which can show associations but cannot prove that the drug caused the problem. And people who take these tablets long term tend to be older and sicker than those who don't, which muddies the picture considerably. So the fair position is that these are reasons for thoughtful review rather than for alarm, and certainly not reasons to stop abruptly on your own. With that said, here's what matters. First, vitamin B12, and this one is well established and genuinely relevant. Stomach acid is required to release B12 from the protein in your food so it can be absorbed, so suppressing acid for years reduces B12 absorption, and long-term PPI use is associated with B12 deficiency. And B12 deficiency after 70 matters enormously because it causes fatigue, anemia, the tingling and numbness in the feet and hands I've covered in other videos, balance problems and memory and mood changes, and if left long enough, the nerve damage can become permanent. So anyone on these tablets long term should have their B12 checked periodically, and that is an entirely reasonable thing to ask for. Second, magnesium, which can fall with prolonged use, and low magnesium causes muscle cramps, weakness, tremor, and importantly, heart rhythm disturbances, so it's another blood test worth having if you've been on these for years, particularly if you also take diuretics as I discussed elsewhere. Third, iron, since acid also aids iron absorption, so long-term use can contribute to iron deficiency. Fourth, calcium and bones, where the concern is that reduced acid may impair calcium absorption, and observational studies have found an association between long-term use and fractures of the hip, wrist, and spine. The evidence isn't conclusive, but given that osteoporosis is already a major issue after 70, it's a sensible additional reason to review long-term use and to attend to bone health generally with the calcium, vitamin D, and weight-bearing exercise I've discussed before. Fifth, infections. And here the mechanism is clear because stomach acid is a barrier that kills swallowed bacteria, so suppressing it increases the risk of certain gut infections, particularly Clostridioides difficile, which causes severe diarrhea and is a genuine problem in older adults, and there is also an association with pneumonia and with small intestinal bacterial overgrowth. Sixth, kidney effects, where there's an association with a type of kidney inflammation and with chronic kidney disease. And seventh, the various headline-generating associations with dementia and stomach cancer, where the evidence is weak, inconsistent, and confounded, and where the honest answer is that these are not established causal risks. So the concerns worth acting on are B12, magnesium, iron, bone health, and gut infections, all of which are reasons for periodic blood tests and a review, and not reasons for panic. Let me cover the interactions, because one of them matters for the heart. The most important is clopidogrel, an antiplatelet medication taken by many people after a heart attack or a stent. Clopidogrel is a prodrug, meaning it must be activated by a liver enzyme, and omeprazole and esomeprazole inhibit that same enzyme, potentially reducing clopidogrel's effectiveness, which in theory could increase the risk of a clot. The clinical significance of this has been debated for years, and the evidence is not clear-cut, but the practical response is straightforward and widely followed. If you need both, pantoprazole or lansoprazole are generally preferred over omeprazole because they interact far less. So if you take clopidogrel and omeprazole together, that is a genuinely worthwhile question for your doctor or pharmacist. Other interactions worth knowing: these tablets can affect the absorption of several medications that need an acid environment, including some thyroid medication, certain antifungals, some HIV medications, and iron and calcium supplements, and they can affect methotrexate and, for some people, warfarin levels. And on the flip side, remember that they are often deliberately prescribed alongside aspirin, anticoagulants, or anti-inflammatories precisely to protect the stomach, and in that situation, they're doing a valuable job. So the clopidogrel combination is worth asking about, and any tablet whose absorption depends on acid may need its timing or dose reviewed. Now, the trap that keeps people on these forever. Here is the phenomenon that explains why so many people believe they cannot live without these tablets, and it's genuinely important. It's called rebound acid hypersecretion. When you suppress acid production for weeks or months, your body compensates, the hormone gastrin rises, and the acid-producing cells actually increase in number and capacity, so you now have more acid-making machinery than you started with, all of it currently suppressed. Now imagine stopping abruptly. Within days, that expanded machinery comes back online at full capacity, and you experience acid symptoms that are often worse than the ones you originally had: heartburn, indigestion, burning, and this rebound has been demonstrated even in healthy volunteers who never had reflux in the first place, which is a striking finding. It means the tablet can create the very symptoms it's used to treat. And here's the trap: the person stops, feels dreadful within a few days, concludes that this proves they genuinely need the medication, restarts it, feels better, and reasonably infers that their reflux is confirmed and lifelong. In reality, a substantial number of them were experiencing withdrawal, not disease. The rebound typically peaks in the first couple of weeks and settles over roughly 2 to 4 weeks. So the practical implication is enormous. If you're going to stop these tablets, you must expect a rough patch, know in advance that it's temporary, and ideally come off gradually rather than abruptly. So rebound acid is real, it can mimic the original condition, it settles within weeks, and knowing about it in advance is what allows people to succeed in stopping. Now, the right way to stop. Let me give you the correct approach to coming off, and please note that this is something to do with your doctor, not on your own, because the first step is establishing whether you're in the group who should stop at all. Assuming you and your doctor agree that a trial off is appropriate, the approaches that work are these. First, taper rather than stopping abruptly. And there are two common methods: either halve the dose for 2 to 4 weeks and then stop, or move to taking it every other day for a period before stopping. Tapering substantially reduces the rebound. Second, have a plan for symptoms during the transition, which typically means using an antacid, the liquid or chewable kind, for immediate relief as needed, or a short course of an H2 blocker such as famotidine, which suppresses acid by a different mechanism and can bridge the gap. Third, use the on-demand strategy afterward, meaning that rather than taking a daily tablet forever, many people do perfectly well taking one only during a flare-up for a week or two at a time, which is a legitimate and widely used approach for uncomplicated reflux. Fourth, and this is where the real work is, address the reflux itself with the measures that genuinely reduce it, and these matter more than people think. Raise the head of your bed by 15 to 20 centimeters using blocks under the bed legs, not extra pillows, which bend you at the waist and can make it worse. Don't eat within 3 hours of lying down, since a full stomach plus a horizontal position is the classic recipe for nighttime reflux. Eat smaller meals. Identify and reduce your personal triggers, which commonly include fatty and fried foods, chocolate, peppermint, caffeine, alcohol, citrus, tomato, and spicy foods, though these vary considerably between people. Lose weight if you're carrying extra around the middle, since abdominal pressure pushes stomach contents upward and weight loss is one of the most effective interventions there is. Stop smoking, which weakens the valve at the top of the stomach, and try sleeping on your left side, which genuinely reduces nighttime reflux for anatomical reasons. And fifth, if you have persistent reflux, ask whether you've ever been tested for Helicobacter pylori, because if that's present, eradicating it may resolve the problem entirely. So taper rather than stop, bridge with antacids or famotidine, consider on-demand use, and do the practical anti-reflux work, which is where the durable answer lies. Let me be very clear about the symptoms that mean you need investigation rather than a stronger tablet, because this matters as much as anything else in this video. Please see your doctor promptly, and do not simply increase your acid medication if you have any of these: difficulty swallowing or the sensation of food sticking, which, as I've said repeatedly on this channel, always needs investigating; unintended weight loss, persistent vomiting, black terry stools or vomiting blood, or coffee ground material, which are urgent; unexplained anemia or fatigue, new indigestion starting for the first time after the age of about 55, or symptoms that are worsening or no longer controlled by a tablet that used to work. Why do these matter so much? Because these are the alarm features that prompt an endoscopy, the camera test, and because acid-suppressing medication can mask the symptoms of something more serious while it progresses, which is exactly the situation where a person feels better on a higher dose while the underlying problem goes unexamined. And two more things worth knowing. Chest pain should never be assumed to be reflux, because heart pain and reflux pain can feel very similar. And if you have chest pain or pressure, especially with breathlessness, sweating, nausea, or pain spreading to the arm or jaw, treat it as a possible heart attack and call emergency services. And secondly, if you've been on these tablets for years and have never had an endoscopy despite ongoing symptoms, that's worth raising. So alarm features mean investigation, not escalation, and chest pain is a heart question until proven otherwise. Let me paint you a picture. Picture a woman of 79 who was started on omeprazole 11 years ago during a hospital admission for something entirely unrelated, as routine stomach protection while she was on other medications, and who was discharged on it and has taken it every morning since. Nobody ever intended it to be permanent. Over the past 2 years, she has become increasingly tired and has developed tingling in her feet and some unsteadiness that her family put down to age, and a blood test eventually finds a significant B12 deficiency. Now, here is the important part of the story. Treating the B12 improves her energy and stops the nerve symptoms progressing, but some of the tingling remains because nerve damage caught late doesn't fully reverse. And when her doctor reviews the omeprazole, there is no current indication for it at all, so she tapers off it over 6 weeks with a difficult fortnight in the middle that she'd been warned about and rode out, and she has not needed it since. 11 years of a medication she didn't need, and a preventable deficiency that has left a trace. Compare her with a man of 74 who takes lansoprazole because he had a bleeding ulcer 4 years ago and still needs regular anti-inflammatory painkillers for his arthritis. He hears about all these concerns, worries, and considers stopping. For him, that would be a genuinely bad decision because his tablet is protecting him from a repeat of a bleed that nearly killed him, and the right action for him is to keep taking it, have his B12 and magnesium checked periodically, and ask whether his painkillers themselves could be reduced. Two people, opposite right answers, and the difference is entirely about why they're taking it. And let me speak briefly to those caring for an older parent or partner. Find out whether they take one of these at all, and crucially, why, because a great many people cannot answer that second question, and that inability to answer is itself the finding. Note that many people also buy these over the counter, so they may not appear on any medication list, which matters for interactions. Ask when they take it, because taking it with breakfast or at night significantly reduces its effectiveness and is extremely common. Push for periodic B12 and magnesium checks if they've been on it for years, and connect the dots if they have unexplained fatigue, tingling, or unsteadiness. Support them through a taper if one is agreed, particularly through the rebound fortnight, because that's where people give up. And carry the alarm features, especially food sticking, weight loss, and black stools, because those need investigation rather than a stronger tablet. So let me draw this all together calmly. Proton pump inhibitors disable the stomach's acid pumps and are genuinely excellent medications, clearly justified for ulcers, Barrett's esophagus, severe inflammation, and as stomach protection for people taking anti-inflammatories, aspirin, or anticoagulants who need it, and entirely appropriate for short courses. The question is the very large group taking them for years with no current clear reason, because long-term acid suppression is associated with B12, magnesium, and iron deficiency, with bone fracture risk, and with certain gut infections, and because stomach acid was doing useful jobs before we switched it off. The trap that keeps people on them is rebound acid hypersecretion, a genuine physiological effect that can produce worse symptoms than the original problem within days of stopping, and that settles over a few weeks, which is why stopping should be tapered, bridged with antacids or famotidine, and accompanied by the practical measures that actually control reflux: raising the bedhead, not eating late, smaller meals, weight loss, and stopping smoking. And running through all of it are the alarm features that mean investigation rather than escalation: food sticking, weight loss, vomiting, black stools, anemia, and new indigestion after 55. So here's what I'll leave you with, straight and clear. First, find out why you're taking it, and if nobody can tell you, that is your reason to book a review. Second, if you take it 30 to 60 minutes before breakfast, because a large number of people are getting a fraction of the benefits simply through timing. Third, if you've been on it for years, ask for your B12 and magnesium to be checked because those are the concerns with the clearest evidence and the most consequences after 70. Fourth, if you take clopidogrel, ask specifically about which PPI you're on because pantoprazole or lansoprazole are generally preferred. And fifth, if you and your doctor decide to stop, expect the rebound, taper rather than quitting abruptly, and do the practical anti reflux work because a great many people who believe they need these tablets for life discover, when they come off them properly, that they don't. These are good medications that are frequently taken for too long by people who no longer need them, and the answer is neither fear nor indefinite repeat prescriptions. It is a 5-minute conversation that a great many of you are years overdue, so take care of yourself, check the timing, ask why, and book the review. And because starting, continuing, and stopping this medication all depend on your individual history, please treat this as a conversation with your own physician rather than a decision to make alone. Treat alarm features like food sticking, weight loss, or black stools as your reason to be investigated promptly, and treat chest pain with breathlessness or sweating as a possible heart attack requiring emergency help.